usually are generated during reperfusion overwhelm the cell's inherent free radical scavenger system, namely the glutathione system. So ischemia leads to decrease in NADPH and glutathione. That's why when the free radicals are created, when reperfusion happens, there aren't enough scavengers to take care of the oxygen-free radicals, which will lead to myocyte necrosis. This diagram also shows the oxygen paradox. So as we said, when there is hypoxia, there is anaerobic respiration, lower pH, and that will lead to calcium overload, myofibril contraction are inhibited. But since we are still in ischemia, the MPTP are still closed. When the coronaries are reperfused, there is a washout of the lactic acid, there is restoration of the physiological pH, oxygen-free radicals are going to be created, and the MPTP pores are going to be open. That will lead to reperfusion injury. So what determines myocardial oxygen demand? Several things such as stroke volume, aortic pressure, or wall stress on the LV, heart rate, basal metabolic rates. And how can we reduce myocardial demand? Myocardial oxygen demand is by cardiopulmonary bypass, diastolic arrest, hypothermia, and ventricular decompression. All these strategies can help in decreasing the myocardial oxygen demand. So this graph here shows that an arrested heart has significantly less oxygen demand than a beating, non-working heart, or even than a fibrillating heart. And as we as the temperature drops, the myocardial temperature drops, the oxygen demand itself drops even further. So this table is just showing the historical perspective of myocardial protection. Research started in the 1950s. The Melrose technique was perhaps the first. Melrose introduced the concept of reversible ischemic, reversible cardiac arrest, and then Brett Schneider in 1964, Hurst DJ emphasized that we need to create a chemical and mechanical arrest of the heart, as well as we have to negate the effects of ischemic injuries. And he popularized this formula, St. Thomas solution number 1. I don't need to spend too much time on this. In regards to cardioplegia, there are two types: crystalloid cardioplegia and blood cardioplegia. We'll start with the crystalloid cardioplegia solutions. They provide little substrate or no oxygen to the heart during a period of ischemic arrest. They function by primarily arresting the heart at cold temperatures. There are two types, intracellular and extracellular. The intracellular types are characterized by absent or low concentrations of sodium and calcium. The extracellular types, on the other hand, contain relatively higher concentrations of sodium, calcium, and magnesium. The rationale behind using crystalloid cardioplegia is that they induce a rapid cardiac arrest using potassium or magnesium. They reduce energy demand and conserve ATP reserves using hypothermia. They maintain intracellular ionic and metabolic homeostasis. They enhance anaerobic and aerobic energy production utilizing glucose and amino acids. They stabilize the pH using bicarbonate, phosphate, or histidine buffers when added to these solutions. Stabilize the cellular membranes by using steroids, oxygen-free radical scavengers such as glutathione, calcium antagonists, or procaine. These are additives. And they avoid intracellular calcium overload by providing hypocalcemic environment and adding magnesium. They prevent cellular edema by the addition of colloids such as mannitol to maintain a normal oncotic pressure. We'll start with examples. One example of the crystalloid solutions is St. Thomas and Plegisol solution. They are extracellular solutions with high potassium levels and produce arrest by depolarization. They require replenishment every 20 minutes to optimize protection. In this table here, we can see the St. Thomas 1 and 2, and these have different compositions. Sodium, it contains about 110 millimoles, 16 millimoles of potassium, 32 millimoles of magnesium, calcium relatively low at 1.2. The buffer that is used in this solution is bicarbonate. The pH of the solution is 7.8. The osmolarity is about 324. Yeah, that's it about the solution. So other solutions that are used is the Custodiol or the Brett-Schneider solution, which is an intracellular hyperpolarizing solution with low sodium and potassium that contains histidine, tryptophan, and ketoglutarate. The histidine provides a buffer and is a free radical scavenger, and this reduces the risk of ischemia reperfusion injury. The solution can provide myocardial protection for up to 2 to 3 hours with just one dose. And when compared to blood cardioplegia, this solution showed similar or even better results in mitral valve surgery and somewhat equivalent results in aortic valve surgery. However, I believe for patients with reduced LV function, blood cardioplegia has shown better results. So the Brett-Schneider is here, the Brett-Schneider HTK. It has a sodium composition of 50 millimoles, 9 millimoles of potassium, 4 millimoles of magnesium, no calcium at all. The histidine is used as a buffer. The pH is slightly lower than the St. Thomas, 7.3, and the osmolarity of 310. They use additives such as ketoglutarate, as tryptophan, and mannitol. Moving on to blood cardioplegia, they are solutions that provide oxygen, natural buffering agents, antioxidants, and free radical scavengers. The standard supplemental additives to this solution include other buffers to achieve an alkaline pH such as CAM, citrate phosphate dextrose or CPD or CP2D to lower the level of calcium, and occasionally drugs to maintain slight hyperosmolarity. The rationale behind using blood cardioplegia is that blood cardioplegia provides an oxygenated environment and a method for intermittent reoxygenation of the heart during a rest. It limits hemodilution when large volumes of cardioplegic solutions are used. It affords excellent buffering capacity and osmotic properties. It allows for electrocyte composition and pH that are almost physiologic, offers a number of endogenous antioxidants and free radical scavengers, and is less complex to prepare than other solutions. The buck-buck solution is one that is used mixed with blood. It produces potassium-induced cellular depolarization and requires replacement about every 20 to 30 minutes. It contains about 20 to 25 milliequivalents of potassium chloride. We can use SAM or bicarbonate as buffering agents. We can add citrate for CPD or CP2D as another additive. Which can be delivered either antigrade or retrograde. The temperature this solution can be given as a cold or tepid or warm cardioplegia, and other additives can be added, including aspartate, insulin, magnesium, arginine, or calcium channel blockers. The other solution is the Del Nido cardioplegia. This solution is a hyperkalemic, low calcium solution that contains lidocaine and magnesium. It contains bicarbonate and mannitol. The myocardial protection is optimized by low diastolic intracellular calcium levels attributable to the presence of lidocaine, which blocks the sodium channels, and the presence of magnesium. All of these are optimized myocardial protection by the solution. So this solution was initially developed for congenital heart surgery, but now has seen more widespread application in adult cardiac surgery. Actually, we can see the composition of the Del Nido here. It has a 140 millimoles of sodium, 5 millimoles of potassium, magnesium about 0.75, 0 calcium, and uses bicarbonates, pH of 7.4, and as we said, we can add lidocaine and mannitol to the solution. When this solution is used with mild hypothermic cardiopulmonary bypass, it provides equivalent protection in patients with and without LVH and with cross clamp for times up to 90 minutes. A dose usually is 20 milliliters per kg to a maximum of 1 liter is given antigrade, and half that dose is given if the cross clamp is going to be less than 30 minutes. The heart usually does not fibrillate after unclamping of the aorta when using Del Nido. If longer cross clamp times is anticipated, redosing with about 10 milliliters per kg after about 45 to 90 minutes is suggested. Regarding the techniques of cardioplegia can be given either as cold, tepid, or warm. It can be delivered through an antigrade method or retrograde, antigrade through the aorta, and retrograde through the coronary sinus. It can be given as intermittent or continuous also. So the temperature of cardioplegia, before the development of cardioplegia solutions, myocardial protection was achieved by systemic and topical hypothermia. It was found that oxygen consumption decreased about 50% for every 10 degrees Celsius decrease in the myocardial temperature. And that led to the belief that hypothermic or cold cardioplegia is the best in regards to myocardial protection. So usually when using cold cardioplegia, the solution is lowered with a heat exchanger coil to about between 4 and 12 degrees Celsius. Regarding the other method, which is warm cardioplegia, it is believed that enzymatic and cellular reparative processes function better as normothermia. Hence, some surgeons prefer using warm cardioplegia to cold cardioplegia, as they believe there may be a reduction in enzyme release and better ventricular function with comparable clinical events. However, because of the tendency of the heart to resume electrical activity at normothermia, this method of delivering cardioplegia has to be given in a continuous manner or only with short periods of interruption to protect the heart. An ischemic time of 15 minutes between repeat administrations is considered safe. There is one study, however, that showed that supplementing the cardioplegia with magnesium, you can safely extend this ischemic time to 25 minutes. Warm cardioplegia can also be used as an adjunct to cold cardioplegia when given just after aortic thrust clamping. We can do something called warm induction, or just prior to removing the thrust clamp, something called the hot shot. So the warm induction involves administering approximately 500 milliliters of warm cardioplegia immediately after aortic thrust clamping. Studies suggest that this may be beneficial in actively ischemic hearts with energy depletion, as it provides a brief period of time during which oxygen can be used to repair the cell and replace energy source. The hot shot or the terminal warm blood cardioplegia is commonly given just before removal of the aortic thrust clamp because it has been shown to improve myocardial metabolism. Another method is the use of tepid blood cardioplegia, which can be given at a temperature between 20 degrees Celsius up to 32 degrees Celsius, allows the heart to utilize more oxygen and glucose than a colder heart. However, most tepid blood cardioplegia studies have been single-center studies, and they were conducted in a relatively small cohort of patients. And still, whether it has any superiority over the other methods of delivering cardioplegia is still to be determined. Generally speaking, all methods, either warm or cold cardioplegia, have somewhat similar results. There is no clear benefit of one method over the other. It mostly depends on the experience of the center and the preference of the surgeon. So this is the circuit of the cardioplegia, as you can see here. This is in case of if it's going to be delivered antigrade. The cannula is just proximal to the aortic clamp. This is the cardioplegic solution mixed with the blood and the heat exchanger and delivered into the heart. And this here is in the case we are going to use retrograde or in conjunction, retrograde and antigrade together. So the route of delivery, we have two routes, as we said, antigrade delivery or retrograde. Regarding antigrade, it entails infusion of the solution into the aortic root, while the ascending aorta is cross-clamped. It is simple and the most commonly used method of delivering cardioplegia. It has some limitations, is that in severe coronary artery stenosis, it may not provide adequate myocardial protection, and in cases where the patient has aortic insufficiency, it will also be insufficient to provide myocardial protection. In this case, we use retrograde perfusion through the coronary sinus and its tributaries which provides another measure of delivering cardioplegia to the heart. It generally provides excellent myocardial protection, and cardioplegia, when delivered through this method, can be given without any interruptions. It can be used to de-air the coronaries and the aortic root. But however, it also has its own limitations, is that it's difficult to place. Usually you will need TE guidance. It can give inadequate RV protection. One reason for this is that as you insert the catheter or the cannula of the retrograde cardioplegia, it goes beyond the entrance of the middle cardiac vein, and thereby you are not delivering enough cardioplegia to the right ventricle. This is one reason of why the RV is not adequately protected. Another limitation or another complication really of retrograde cardioplegia delivery is coronary sinus injury, which is quite rare, but it can be fatal. The rule of thumb is not to let the coronary sinus pressure exceed 50 millimeters of mercury, as it will cause rupture of the coronary sinus, and not to let it be below 30 millimeters of mercury, as that is too low of a pressure. Usually, when using retrograde cardioplegia, the rate of delivery is about 200 milliliters per hour. So this diagram here shows the different types of cardioplegia delivery. This is the antigrade method and the aortic route, and this is the retrograde cardioplegia cannula. So regarding the operative procedure or the method of delivering cardioplegia. So to initiate an immediate chemical arrest after cross-clamping the aorta, the solution is infused through the cardioplegic catheter, either inserted to the aorta proximal to the cross-clamp. The cold hyperkalemic crystalline solution is then infused at a volume generally that does not exceed 1,000 milliliters. One or more infusions of 300 to 500 ml of the cardioplegic solution may be given if there is evidence of resumption of electrical activity of the heart, or if a prolonged ischemic time is anticipated. If myocardial revascularization is being performed, the aortic cross-clamp can be removed after completing the distal anastomosis of the heart, and you can let the heart reperfuse, and you can anastomose the proximal segments of your vessels while using a partial occluding clamp. Another approach is to perform the proximal aortic graft first, and then with a partial occluding clamp, and then cross-clamp the aorta and start the giving cardioplegia. Or alternatively, you can do both the distal and the proximal whilst on the cross clamp under arrest. So when valvular repair or placement is being performed, the crystalloid cardioplegia can be administered directly into the coronary arteries via cannulation of the coronary ostia. The crystalloid cardioplegia can be administered through retrograde via coronary sinus, as we said. So most studies suggest that in low-risk cases, multi-dose cold crystalloid, tepid or warm blood cardioplegia, whether given antigrade or retrograde, all produce relatively comparable clinical results. In general, protection of the RV is suboptimal with all strategies, especially in patients with right coronary artery disease. A combined antigrade and retrograde cold, tepid, or warm blood cardioplegia approach seems to be best for high-risk patients. The del nido cardioplegia appears to provide excellent protection, but the timing of delivery to optimize protection in cases requiring prolonged periods of cardioplegic arrest has not been clarified yet. It says 15 minutes of ischemia time, or 25 minutes if you add magnesium to it. So for blood cardioplegia strategy, this is an example of a strategy that can be used for using blood cardioplegia. So you can use warm induction for severely ischemic hearts and use cardioplegic arrest with about 1 liter of cardioplegia. You give about 750 milliliters of antigrade infusion, followed by 250 ml retrograde. And the latter is especially important in patients with severe coronary artery disease. If the temperature monitoring is used for cold cardioplegia, it should be maintained at less than 20 degrees Celsius. The amounts of the antigrade and retrograde cardioplegia delivery may need to be modified depending on how effective they appear to be, based on the nature of the coronary disease, temperature, or pH monitoring. For valve surgery, after the initial antigrade dose, using either continuous warm retrograde cardioplegia or intermittent cold retrograde blood cardioplegia with a low potassium solution every 20 minutes. If aortic insufficiency is present, administering the cardioplegia retrograde, and if there is a large right coronary artery, consider antigrade administration right into the coronary ostium itself. For redo aortic valve surgery in patients with patent ITA, the ITA pedicle may be left unclamped, systemic hypothermia to at least 28 degrees Celsius, with the use of continuous cold retrograde blood or blood cardioplegia should provide adequate myocardial protection. In regards to coronary surgery, perform a right coronary artery graft first and administer low potassium cardioplegia down that graft simultaneously with retrograde cardioplegia for all subsequent administrations. Antigrade delivery cannot be delivered down the pedicled ITA graft and is best avoided in free grafts, ITA or radial artery, to avoid potential adverse impact of graft manipulation and hyperkalemia on endothelial function. So administering cardioplegia down each saphenous vein bypass graft as it is completed along with additional retrograde cardioplegia. Concomitant administration down all completed grafts along with retrograde cardioplegia might be helpful. If it is elected not to use retrograde cardioplegia, alternating distal and proximal anastomosis will allow for antigrade delivery down the completed graft. The duration of aortic cross-clamping is lengthened when both proximal and distal anastomosis are performed using a single aortic cross-clamp period rather than performing proximal anastomosis with partial aortic cross-clamping. If warm retrograde cardioplegia is used, it should be run as continuously as possible as long as it does not interfere with exposure. A high potassium solution should be used if there is return of electrical activity. Administer approximately 500 ml of hot shot retrograde just prior to removal of the aortic of the cross clamp. If retrograde cardioplegia is not used, give this into the aortic root at a pressure that does not exceed 50 to 80 millimeters of mercury, after ensuring that there is no air in the aortic root. This is probably only beneficial in hearts where actively ischemic or after long cross-clamp times. The addition of aspartate, glutamate, and to the reperfusion solution may have benefits in actively ischemic hearts. In circularly arrest cases for aortic root and arch surgery, cardioplegia should either be administered directly into the coronary ostia or given retrograde just prior or at the time that circulatory arrest is initiated. Careful adherence to the basic principles of cardioplegia, including maintenance of arrest, antigrade or retrograde delivery, multi-dosing, and in particular for Buckberg type solutions, should allow surgeons to patiently yet expeditiously perform even the most complex, time-consuming operations without worrying about poor myocardial protection. These are my references, and thank you very much. And if you have any questions.
Thank you, Dr. Sultan, for this informative presentation. Anyone has a questions? You can hear me?
Yes, Doctora, we can hear you.
Anyone has a question for Dr. Sultan? Okay, Dr. Sultan, I have a question about the RV protection retrograde. Is it correct that the RV, there is a questionable protection of the RV in the retrograde? Because I read in some books that there is the RV is not protected optimal in retrograde. However, in some in other books, if the retrograde cardioplegia is done perfectly, so there is no worrying about the RV protection. Is this correct or?
Well, you're right. I found different books say different things, but from what I read is that, in generally speaking, RV protection is usually suboptimal. It's more difficult to achieve than protecting the LV, even when you use retrograde protection. One cause, as I mentioned, is the anatomical causes, because you are placing the cannula after the entrance of the middle cardiac vein, which drains the RV. So you are not infusing the middle cardiac vein with any cardioplegic solution. That could be one of the reasons. Another reason is that the RV is generally not well drained as well as the LV. So these can all contribute to suboptimal RV protection.
Okay.
Yeah.
Okay, thank you.
Thank you very much.
Okay. Any questions?
Assalamu alaikum. Do you have a consultant with you, Sultan?
No, Doctor, I could not arrange with them. Nobody was free.
Okay. So just comments, practical questions or comments for you and for your colleagues. What you mentioned about the middle cardiac vein, I think is a very important point that you should be aware of. There are technical issues that people have to pay attention to in the antigrade and the retrograde. You mentioned Del Nido solution, so you need to know how much potassium you have in Del Nido, and do you use lidocaine in that? And how does that compare with custodial? Those are the most commonly used currently, the most commonly used techniques, but still some people are using only crystalloids solution. It's called let me just remember the name. I can't, such an old time since we use those separately. But anyway, and the blood. So we have the blood containing cardioplegia and crystalloid cardioplegia. Out of those two, we have developed the Del Nido, which is just like I said, one of the most common used, and the custodial, which is by far now is the most common, mainly because the period that you use is extended. So you don't have to use it more than once for about 2-3 hours for ischemic time, which is enough time for to do basically all kind of cardiac surgery, including transplant. Anyway, so those are the things that I alluded to, and you mentioned a lot about the theory and the experimentation that happened in the beginning of the development of cardioplegia, which is out of interest for you to know and maybe for your colleague to read. I think the most current one that's have alluded to the discussion of the molecular changes that happen with the cardioplegia is the one that's talk about custodial, and it was given by a famous cardiac technician. I think it's from Germany. I can't remember the name or the date, but it was in the last 5-6 years, something like this. Okay, well, thank you very much. It was very nice and in-depth review. But just like I said, I mentioned some of the technical and practical questions that you may be asked in the exam. Thank you.
Thank you very much. Thank you, Doctor.
Thank you, Dr. Farid. So we can take like a 5 minutes break, then we can start with the second lecture.
Okay. Can you hear me, guys? Are my slides clear?
Yes.
واضحة.
Okay. So before starting, I would like to thank Dr. Abdullah for attending. I would like to thank him for his support. I really appreciate his presence. Dr. Abdullah, are you there?
Yes, I'm here. Thank you.
Thank you for attending. I really appreciate that. So Dr. Abdullah is a pediatric cardiac surgeon in our hospital at King Faisal. So he's gonna, inshallah, give some comments about the presentation about the topic. And if we have any question, you can ask him. You can ask Dr. Farid, or also if you have any question from the audience, we can discuss. So inshallah, we're gonna talk about deep hypothermic circulatory arrest and brain protection. Let me see why I cannot move the slides. Give me a second. Okay, so to start with, this is me and Dr. Abdullah operating on a baby. Okay, so I just wanted to put it so you know that how I really appreciate your support, Dr. Abdullah. And these were my references, key questions, and Lawrence, and some articles also, some information from some articles. So to start with, this is a table from Annals of Cardiothoracic Surgery. So just to start with, so how can we classify hypothermia and circulatory arrest during the aortic arch surgery? So if we go down with the temperature like by 14 degree, then we call this profound hypothermia. If we go like from 14 to 20, it's deep hypothermia. If we go between 20 to 28, this is moderate hypothermia, and then mild is 28 to 34. So these are the classifications of hypothermia. These are some recommendations also from the same website. So during deep hypothermic circulatory arrest, you have to have multiple things in mind. You have to take multiple things into consideration, so you can protect the brain, you can protect the patient, and you avoid the major complications that are going to happen after the surgery. So membrane oxygenator, arterial filter, epi-aortic ultrasound to detect any atherosclerosis of the aorta. You can use it as a strategy to prevent dislodgement of the atherosclerosis. Hyperthermia, you should avoid that. We are going to talk about it. The alpha stat, pH stat that we are using during surgery, during deep hypothermia, what strategy we can use and what strategy is beneficial in adults and peds. The rewarming strategy, how can we monitor the brain activity, for example, and then the pressure that we are going to keep on, the avoidance of hyperglycemia, also the transfusion. No need to give, for example, the transfusion unless the hemoglobin is less than 7, depending on the patient also risk. So these are some recommendations. And then to start with, a decrease from a baseline mean arterial pressure more than or equal to 10 mmHg during cardiopulmonary bypass. It's associated with threefold higher risk for watershed strokes. So high MAP is better than the low one, especially in high-risk patients. And as a definition of deep hypothermic circulatory arrest, it involves reducing the body temperature to less than 20 degrees. You arrest the circulation for a short time, you complete your operation, and you rewarm to 37 degrees. Indications are surgeries that are done on the aortic arch, which is usually our indication on our patients. Heavily calcified aorta is one indication, thoracoabdominal aneurysms, some neurological procedures, some certain complex congenital heart diseases, to control also and repair a source of massive bleeding. You can sometimes use deep hypothermia to control the bleeding. The benefits of deep hypothermia, so you reduce the cerebral oxygen consumption. So at a 20 degree, cerebral metabolism and oxygen consumption there is gonna be like 20%, 20% less of the normal or the normothermic levels. So there is a drop by a 5% for each 1 degree, a drop in the temperature. Okay, so this the cerebral oxygen consumption is gonna decrease, and this is what we want so we can protect the brain. And then it decreases the release of the toxic neurotransmitters. It decreases the release of reactive oxidants during ischemia and reperfusion. And here you can see, as you go down with the temperature, then the cerebral oxygen consumption is gonna go down. Okay, so within like with each each 1 degree drop in the temperature, there is 5% drop in the cerebral oxygen consumption. How can we initiate and how can we monitor the patient during deep hypothermic circulatory arrest? So to start with, what are the steps that we do? Okay, so we can initiate. So like the regular things that we are doing to start any surgery. So I mean the major cardiac surgeries. So we establish cardiopulmonary bypass, right? So we can decrease the temperature. And then we keep steady hypothermia, like a 15 to 18 degree for 10 minutes before going into the deep hypothermic circulatory arrest. And why we're doing this? Because you don't want the brain, the brain activity to be suppressed, and you don't want the brain to be rewarmed. So you give first steady hypothermia, you keep it that way for like 10 minutes, and then you go with the deep hypothermic circulatory arrest. So once you reach the temperature, the desired temperature that you want, which is usually deep one means like 18 degree, then you switch the pump off. You tell the perfusionist to stop the pump, and then you clamp the arterial line. You drain the circulation, the whole circulation and the volume into the venous reservoir, okay? And you do your operation. Once you are done with your operation, then you ask the anesthesia to put the head down. It's like deep head down, okay? Trendelenburg position. So you can de-air and to get rid of any pupil you are having. And then you restart the circulation at a slow rate, like 500 ml per minute in an antigrade direction, okay? And you give a period of cold reperfusion for 10 minutes, okay? So you maintain that cold reperfusion at 15 to 18 degree for 10 minutes before you actively rewarm the patient. And the active rewarming means 0.2 to 0.5 degree per minute after establishing cardiopulmonary bypass. So we do want a rapid rewarming, and we're going to talk about that. So for monitoring, we are using esophageal, rectal, bladder, or pulmonary artery temperature for the body. Not all of them are used in our OR, but these are the strategies that we are using to detect the temperature of the body. And nasopharyngeal and tympanic temperature for the brain. So in OR, I mean, I'm talking about our OR, we are using the rectal and we are using the nasopharyngeal, okay? And then you cool down. So when I have to stop, so you have to have a minimum of 30 minutes cooling down. You have to have an EEG silence, which is no more used because it's not reliable. You cannot rely on EEG to say that the brain activity is now less. You can have a jugular venous saturation more than 95, means the oxygen consumption in the brain is less. and then nasopharyngeal temperature of 15 or bladder temperature of 18. You can use the NIRS, the near infrared spectroscopy, to detect, to give you indirect impression about the brain oxygenation and so on. And you use hypothermia blankets and ice packing of the head to help in cooling and prevent rewarming during the circulatory arrest period while you are doing your procedure. So for rewarming, it should be started with short period of low pressure, cold blood flow. So this to reduce, to decrease the ICP, the intracranial pressure and the cerebral edema. So you don't want to rapid rewarming. It improves the cerebral perfusion when you do it this way. As recommended earlier, we said avoid hyperglycemia. It induces brain injury, leads to acidosis, prevents return to normal cellular metabolism. Avoid hyperthermia. It increases the risk of neuronal cell injury, worsen neurobehavioral outcomes, and maintain the hematocrit. So this decreases events of brain injury, increases buffers and free radicals scavenging capacity. So how much hematocrit we want? It's roughly talking, generally speaking, I'm sorry, that you have to, they are saying you have to keep the hematocrit the same number as the temperature that you have reached. For example, 80% hematocrit because of the temperature is 18, sorry. So this is what they generally recommend, but this is generally speaking, yani. Because when you go down with the temperature, then the hematocrit also should go down. So there is no sludge in the capillaries also. Means because you are reducing also the oxygen capacity also. So we have to decrease the hematocrit. And then talking about alpha stat, pH stat, these are the strategies that we are using for pH management. So we have two strategies. We have pH stat and alpha stat. For pH stat, so they are saying that it gives homogeneous cooling, okay? But it has also some adverse effect on the patient. So it maintains a normal pH at hypothermia by adding CO2 during cooling. Okay, and the blood will be acidotic, hypercapnic when the blood rewarmed to 37 because you're adding CO2. It's used during cooling as it enhances cerebral perfusion by eliminating autoregularity capacity. But in the other hand, we have the alpha stat. So it maintains normal acidemia, blood gases at temperature of 37. And the pH, it allowed to change as the blood temperature decreases. So it's drifting only. It's not active. It's just a drift. And then the blood will be alkaline and hypocapnic. It's the opposite of the other one. And then it's usually used during rewarming. It reduces microemboli. So this is what they are arguing about, that alpha stat is good because it reduces the microemboli, despite that the pH stat is giving good homogeneous cooling. So for adults and children, so usually they use pH stat for pediatrics, but what I have read that it's not a rule. So it's not a rule in all patients. So some are using alpha stat in children, some are using the other way around, and then it's different between cooling and rewarming and so on. So it's not a rule that for adults alpha stat and for peds pH stat, but usually we are using pH stat for peds. Talking about safe duration, so as you go down with the temperature, then you have more time to do your procedure, right? So with a temperature of 36, then you have only 1 minute, and then you go down till you reach, for example, 16. For 16, at a degree, at 16 degree, you have like 45 to 60 minutes safe duration to complete your procedure. So circulatory arrest of more than 30 minutes, it's associated with increased mortality and adverse neurological outcomes. So you have to keep the arrest period less than 45 minutes, okay? And if operation allows, also you perfuse for 10 to 15 minutes between arrest periods of 10 to 20 minutes. So you perfuse for duration of 10 to 15 minutes between the arrest periods that last 10 to 20 minutes. Okay, so these are the recommendations for the safe duration. And then moving to complications of deep hypothermia. So coagulopathy, platelets dysfunction, systemic inflammatory response are really major complications of deep hypothermia. They lead to capillary leak, tissue edema, organ dysfunction, and then neurological injury because of embolism and the inflammatory response. So brain injury during hypothermic circulatory arrest, it might be temporary or permanent. So temporary is reversible. Patients might have confusion, agitation, delirium. They don't have a focal deficit usually, and they have normal imaging, and they get global ischemic injury. This is for the temporary one. For the permanent, they're gonna have strokes because of particulate or gas embolism. It causes vascular occlusion, and the risk factors are atheromatous disease involving the ascending aorta and the site of arterial cannulation for cardiopulmonary bypass. That's why they encourage to use epi-aortic ultrasound, so you can know where you put your cannula. Moving to brain protection. So for brain protection during deep hypothermia, there are two strategies to protect the brain. So you have antigrade and you have retrograde. We're going to start with the retrograde one. So retrograde, it has benefits as well as the antigrade, and some are recommending this, some are recommending that. So let's start with the retrograde one. So it flushes embolic material. It maintains cerebral hypothermia. It supports the cerebral metabolism. It improves the auto delivery to the brain and increases the levels of ATP and reduces lactate production. The flow is going to be 300 to 500 ml per minute to maintain SVC pressure of 20 to 25 mmHg. And if it is done in the right way, so do you think it's going to produce dark or bright blood? What do you think, guys? Abdullah. الهداب. Abdullah's not okay. طيب, anybody else?
Dark.
Dark blood? This is Noura?
Yes.
طيب, anybody else has a comment on Nora's answer? I cannot see all the names. Anybody can help? Muhannad? طيب. So let's move to this. So this is a drawing by Dr. Abdullah last night. He wanted to make things easier for me, so he gave me this drawing. So as we go on pump, we establish cardiopulmonary bypass, and then we wanted to go into deep hypothermic circulatory arrest, right? So the retrograde cerebral perfusion is going to be through SVC. Okay, so it's going to be retrograde through the arterial cannula. So the SVC cannula is connected to the arterial one through a Y connector. But we said earlier that our arterial line is clamped already, right? So the perfusionist, when I asked him to give retrograde cerebral perfusion, when I asked him to perfuse the brain retrogradely, then he's gonna give blood through the arterial cannula into the SVC, and then will perfuse the brain, and will get back to us through the the great vessels. Here we are operating on the aortic arch, right? We said earlier that the operation is here. Yeah, exactly. So if I have good perfusion to the brain, that means I'm gonna have the bright blood. If I have if the brain perfusion is not good, then I'm gonna have dark blood. Right? Yeah. So this is the thing this is the concept that I wanted to talk about, right? Dr. Abdullah, any comment on this?
Yes, no, that's a good explanation. It's basically like you're mentioning in this diagram. You're going to get back return, assuming you haven't clamped the head vessels. You'll get back some return from there. But the other thing is you have to make sure you haven't clamped off the head vessels, because you have to have some way to get that blood drained from the head. So yes, and then the concept is, we use that concept of a conveyor belt, where you have, you can give that example as well. But nevertheless, the brain is extracting oxygen at a relatively fixed rate at that temperature. And the amount of oxygenated blood flow that you provide to the brain will determine the oxygen content coming back. And like you just described, correct?
Yeah. So here, when we see the blood, we know that there is, for example, if we see the darker blood, then we tell the perfusionist that we have to do something. So what do you think, guys? What can we do if we see darker blood and we want to do something for the brain? What can we tell the perfusionist so he can or she can help us? Anybody can answer.
Possibly if they can monitor the blood pressure.
Yeah, but before blood pressure, what do you tell them before pressure? So you wanna more flow to the brain, right? So you tell them to increase the flow, and then Anud, excellent that you have mentioned the pressure. So when you increase the flow, also you have to monitor the pressure. So you have to keep that pressure reading that we have mentioned earlier, right? Thank you, Anud. Okay, so this is another picture just to make things more clear. So this is the the cannulas in the ascending aorta, and we have the one in the SVC. And then we are asking the perfusionist to perfuse the brain through the arterial cannula into the SVC, into the brain, and then the blood is gonna get back to us here. Okay. Moving to the antigrade one. So the antigrade one, it improves the cerebral perfusion. It improves the overall neurologic outcomes. It's superior in preventing a temporary neurological dysfunction. It increases the risk of air or atherosclerotic emboli. So this is what we're talking about, that they are saying that the retrograde one is superior, and thus it decreases the emboli and everything. It washes out the emboli. And then it has higher incidence of stroke. We perfuse with cold blood at 10 to 18. degree, and we flow with a rate of 10 ml per kg per minute. The perfusion pressure is restricted to 30 to 70 mmHg. Why? Because you don't want to dislodge any atheromas. And then a complete circle of Willis is required. Yes, they are saying it's required, but it doesn't mean that we have to scan all the patients before going to surgery to check if they have complete circle of Willis or not. And we're going to talk about that in a while. Right, so this is a picture to show the antigrade one. So you have a cannula here, axillary cannula. They cannulated the axillary, okay, directly or with a Gore-Tex here, okay, and they are trying to perfuse the brain through the axillary. So they snared all the great fizzles so they can have good flow through the axillary one. Some are doing also the brachiocephalic, okay, so they're perfusing the brain via the innominates, or the left also common carotid. You can do that. It's not only the axillary. So there is no difference with or without intact circle of Willis, as I read in one of the articles. And they're saying, so regarding antegrade versus retrograde cerebral perfusion, they're saying in proximal arch operations using deep hypothermic circulatory arrest, equivalent early and late outcomes can be achieved with retrograde and antegrade, although the mean operation time is significantly less with the retrograde one. Why? Because we are not doing the axillary cannulation, not because of something else. So they're saying they are the same. So can we conduct deep hypothermic circulatory arrest without cerebral perfusion? Yes, we can do that without cerebral perfusion. So you can, some articles are saying that you can concentrate on your operation and you forget about cerebral perfusion. So you can do your surgery fast, and then the deep hypothermia itself, it's gonna protect the brain. So no need to perfuse, and you can complete your operation, forgetting about cerebral perfusion and those stuff, so you can complete your operation fast. What about moderate hypothermia with antegrade cerebral perfusion? So these are some articles talking about this. So moderate hypothermic circulatory arrest with antegrade cerebral perfusion yields excellent and equivalent outcomes to deep hypothermic circulatory arrest for elective aortic hemiarch reconstruction. It improves intra-op time and importantly reduces transfusion requirement compared with the deep hypothermic circulatory with a retrograde cerebral perfusion strategy. So yeah, we can use that. But I didn't see it. I saw only the deep hypothermic circulatory arrest. And then here they are talking about the impact of deep versus moderate hypothermia on post-op kidney function after elective aortic hemiarch repair. So they're saying here that they applied the sensitive, the rifle criteria and so on to examine the AKI in patients undergoing elective aortic hemiarch replacement for aneurysmal diseases. So compared with deep hypothermic circulatory arrest with retrograde cerebral perfusion, their data suggested that the moderate with antegrade cerebral protection strategy just does not appear to be associated with worse post-op renal outcomes. This is the last slide I have. So for pharmacological adjuncts, you can use some medications to also to help in protection. So for methylprednisolone, you can use 1 gram to reduce the risk of permanent neurological dysfunction. You can use mannitol, 1 milligram per kg. It decreases cerebral edema, has a free oxygen radical scavengers, and has anti-apoptotic effect after brain ischemia. Also, you can use barbiturates, which I have seen in our during our surgeries. So it reduces cerebral edema and autoconsumption. But what I've read that it has a negative ionotropic effect. That's why they are not in favor of using barbiturates. And correct me if I'm wrong. And thank you. Dr. Abdullah, any comments?
No, overall, comprehensive presentation.
Thank you.
You touched upon this briefly, and this is open to the entire group as well.
Mhm.
Which operations do you think you might need deep hypothermia for?
So for adults, we are usually doing that with the arch, and with beads, the arch and Norwood.
So the Norwood. What about the Norwood? Because of the. Why did you say Norwood?
I'm not sure about my answer, but this is what I know.
So, correct. You're probably implying the arch component in the Norwood, right?
Yeah.
Sure. Let's see. Unfortunately, I don't know everyone in the group, but maybe I can pick someone's name here and get to know them. Dr. Abdul Karim Abu Khader, are you there?
Yeah.
Yes. Can you introduce yourself?
My name is Abdul Karim Abu Khader. I'm an R1.
You're R1. Okay, mashallah. So maybe I'll be very impressed if you if you're able to answer this. But can you think of maybe another operation where this may be helpful? This strategy.
A deep hypothermia.
Yes. And it's okay if you're
Anything, I guess, that would cause malperfusion to the cerebral arteries, I guess. Anything working, like, for example, anything where you'd be working on the arch, like a total arch replacement, for example. That's
right, like Dr. Ayat mentioned. Correct. So, another, and this is an actual case that we encountered during one of our trips abroad. When you have a chance to go on a mission trip, either outside the United States or outside of Saudi Arabia, you'll find patients that, especially in pediatrics, you'll find patients that'll present quite late sometimes for their congenital heart repairs. And one type of patient is a very common patient, is a patient with tetralogy of Fallot. Mm-hmm. So when you have tetralogy of Fallot, we don't necessarily employ this technique, but can you imagine a situation where a child has long-standing tetralogy of Fallot, their SATs are relatively low. What I mean is, in the high 60s, maybe low 70s. They have features of clubbing. What do you suspect happens naturally over time in these children? Dr. Al-Sulbud, are you there?
So, Dr. Abdullah.
Yes.
Your question is about the
what do you think?
Presentation of TOF.
Tetralogy of Fallot. What do you think happens? How do these children try to compensate physiologically for their decreased saturation?
They have collaterals. They develop.
Yes, correct. So they develop. Obviously, they develop a higher hematocrit. Mm-hmm. Some of them, but they develop collaterals. What kind of collaterals do they develop?
to where or where are they gonna?
Yeah. What type of so what is the body trying to do? It's trying to achieve more
oxygenation,
pulmonary blood flow.
Yes.
Right. So what type of collaterals do you suspect would develop over time? So what do we do for a child who comes with tetralogy of flow, who's cyanotic, who's presents like in their, or like a neonate or a infant, if we don't want to do complete repair? What is the strategy? What is our palliative strategy for that kind of a child?
You do a PA band?
Think about your answer.
BT shunt.
Yes. Who answered?
Face comedy.
Can you introduce yourself, Doctor? Where?
Doctor, my name is Faisal Al-Ghamdi. I am an R5.
MashaAllah. Very good. And where are you resident?
From King Saud University, Medical City in Riyadh.
MashaAllah. Great. So absolutely, BT shunt. That's what you do for an early palliative operation for tetralogy of flow. So if you think about what we're doing synthetically with a BT shunt, what do you think is naturally happening over time with these kids?
Aortopulmonary collaterals.
Absolutely. Aortopulmonary collaterals. And then if you put a child with a bunch of aortopulmonary collaterals that haven't been dealt with, say in the cath lab, and you go on cardiopulmonary bypass, what do you think would happen?
You will drown the lung.
Yes, you could drown the lung, yes. And what else? Where does the blood go from the lungs?
It goes back to the heart and it will be distended.
Yes, exactly. It'll go right back to the heart and it'll be distended. And your peripheral perfusion can be compromised to the other organs as well.
Because most of the blood went to the lungs. Because it's a low resistance.
Yes, went to the lungs and then to the heart. Exactly.
I understand.
So now, this was a real case that we had. We had a couple of years ago, a child presented at the age of about 12 for his repair, and he had, in fact, 2 shunts that were placed on him. But even despite that, he had clubbing and was dusky. And as soon as we put him on cardiopulmonary bypass, there was a very dramatic. We didn't have any cath data, but it was a very dramatic distension, almost like the heart was ready to explode. Just a sudden distension of the heart, and it was just not effectively, able to squeeze out that blood. So we had no choice but to cool this patient down to deep hypothermia while we did cardiac massage to make sure that the heart, didn't develop endocardial ischemia. So, and then under a period of deep hypothermic circulatory arrest, because there was so much return coming that even if we cross clamped, there was just so much return coming back into the heart. We still, it wasn't effective. So anyway, so this strategy was employed in that child for his intracardiac component of his repair. But good, very good. I don't know how much time we have, but
we still have time if you have more comments, Dr. Abdullah.
Okay. So one other, does the group have any questions about I know you touched upon this pH stat versus alpha stat? So,
Doctor?
Yes.
Regarding pH stat and alpha stat, I have a confession that I have never understood this subject. Whenever I read it, I just memorize it for the exam and then I forget it. I don't know, maybe you can make it clearer if you can explain it to us again.
Yeah.
Because I think it has rooted a lot in the basic science, which an aspect maybe I think I'm weak in. So can you please explain it again for us if you don't have the time?
Sure. So basically, the basic concept, alpha stat is the simplest way to think about this is that you are doing just a simple cooling. Okay, the perfusionist is perfusing and cooling the temperature down in the process. Do you recall from physiology what happens to the what happens to the carbon dioxide as you're cooling the temperature in a solvent like blood?
It will dissolve.
It will dissolve. Yes. So more and more of the carbon. So in any solvent, right? You have a certain amount of content of gas, and then you also have, the gaseous component, which is so the dissolved component, the gaseous component, which we measure as a partial pressure of that gas. So the partial pressure of carbon dioxide, if more carbon dioxide is going to dissolve in the gas, what do you suspect will happen to the partial pressure of carbon dioxide?
It will decrease?
Yes. So the carbon, correct. So it would decrease. So as the temperature goes down, you'll have the partial pressure of carbon dioxide also decreasing. Now, what effect does that have on the cerebral vasculature? A decreased partial pressure of carbon dioxide.
Vasoconstriction?
Vasoconstriction, correct. So, so to counter that vasoconstriction, what the perfusionist will do is they will infuse carbon dioxide into the circulating, blood, into the circuit. And as they infuse carbon dioxide, what they're essentially doing is trying to maintain the partial pressure of carbon dioxide and in return the pH of the gas. So they're trying to maintain a stat or like a constant pH or partial pressure of carbon dioxide as the temperature goes down. And the motivation for that is to prevent what you just alluded to, which is vasoconstriction, cerebral vasoconstriction. And when you do that, when you try to prevent cerebral vasoconstriction, especially in children, you can maybe with a little bit more comfort, assure that the cooling distribution or the flow distribution through the brain is a little bit more uniform. If you were to do that on the adults, what do you think adults are a little bit more prone to or at risk for?
Embolic stroke or?
Yes, so so the microemboli, right, and hence alpha-stat has most of the adult practices have gravitated towards alpha-stat, and I would say there's partly a mixture of pediatric practices that some do alpha-stat, some do pH-stat. Now, does that somewhat answer your question, Dr. Faisal?
Yes, doctor, it answers my question, but I have two more in the same topic. First, why the adults are more prone to microemboli when compared to the pediatrics? And the second question is, when I was reading about this topic, there was this term of ABG corrected to the temperature and not being corrected to the temperature. Where does that fit exactly in the alpha stat and the pH stat?
So to answer your second question, ABG correcting to the temperature is an active process. So just like we described, that would, so basically you're correcting the ABG or the pH to the temperature. So what happens to the pH as the temperature goes down? The pH tends to go
increase
up. So you're correcting by infusing carbon dioxide, right? So that's basically the pH stat strategy. And when you're not correcting the ABG in terms of the pH, that's alpha stat. So think of the alpha stat as do nothing, and pH stat is an active process of pushing in carbon dioxide during cooling and then sweeping it away upon rewarming.
Clear, doctor.
Okay. And I'm sorry, your first question was again?
You said usually in adult they use alpha stat because they are more prone to microemboli. Why the pediatric are not the same?
You know, it's a very good question that you asked, and I think that can be debatable. You know, when I was in Nebraska, and I don't know if this has been published yet, but I think that it's an assumption that adults have more microemboli than pediatrics. Yes, adults can have, you know, generally more atherosclerotic plaques and can have, you know, little pieces of microemboli. But, you know, when I was in Nebraska, the engineers there were developing this transcranial Doppler helmet for babies. And what they wanted to do was they wanted to measure, you know, the cerebral embolic load. And it was fascinating. They found spikes of this even in babies, especially during periods of cannulation and going on bypass. So again, yes, I think to answer the why question may be related to multiple other factors and atherosclerotic disease in adults, but again, I'm not sure that the pediatric population is also totally immune from that because they don't have atherosclerotic disease.
I understand. Thank you, doctor, very much.
You're welcome. The other thing that was interesting, and I'll just on a historical note, as I'll leave you. This is from Boston Children's. So they, in 1985, they changed their strategy from pH stat during hypothermic cardiopulmonary bypass to a more alkaline alpha stat strategy. And prior to that, they were doing the pH stat strategy. And then they started to realize that then they actually switched back to the pH stat strategy. And what they found was, this is based on a retrospective study, they found that they looked at patients who had undergone transposition repairs. This included now Sennings, and later on these were arterial switches as well. And a lot of these kids were done at that time under a period of hypothermic circulatory rest, with the average range of about maybe 43 minutes. The average being 43 minutes and a range from about 35 to 60 minutes. And what they found was that the duration of circulatory rest was not associated with cognitive outcome. However, a strong positive correlation was found between the arterial PCO2 during cooling before circulatory rest and the child's developmental score. So, children who were undergoing the alpha stat strategy had a worse developmental outcome compared to the ones that were undergoing the pH stat strategy. And their hypothesis was that maybe during the cooling phase, that's really where it's not so much the circulatory arrest phase, but it's the cooling phase that is critical, and making sure that the brain is getting, not differentially perfused or cooled, but rather more uniformly cooled. So it was interesting.
Like the usual, Dr. Abdullah, right?
Sorry?
Unlike the usual that we are doing for beads.
Yeah, and yes, and then it's also before that time, there were no, when they were using pH stat strategy, they had no chorioathetosis, and then after 1985, between 1986 and 1990, when they started to introduce the alpha stat strategy, they had 19 cases of chorioathetosis. So, granted, but that's still it's a small number compared to the number of cases that were done there, but still very interesting findings.
So we can use, for example, to start with a strategy, and then we switch to another one during rewarming, for example, during cooling, and then rewarming another strategy.
Well, if you've used one strategy during cooling, you will have to deal with, you would have to think about it. So if you are saying, I'm going to do pH stat strategy during cooling, so what are you doing during that period of time? What is perfusion doing during that period of cooling?
The pH one?
In the pH stat, what are they actively doing?
They are adding CO2.
They're adding CO2. So now when you're if you've added all the CO2, and now when you're rewarming,
we have to get rid of that CO2.
You have, or otherwise you'll be, what would happen to your pH if you don't?
So it's going to be more acidotic.
Correct. So you have to. So pH stat strategy means once you've chosen one path, you have to do that thing for both the cooling and the rewarming. Okay. Any other questions before we finish?
Guys, do you have any question, or we conclude? Any comment, any questions to Dr. Abdullah, to me, Dr. Khogir? Dr. Khogir, do you have any comment?
Yes. Sorry for this. I got some other connections there, but Al-Walid, is he there? Hello?
Yeah, Al-Walid, I'm not sure. Al-Walid, are you there?
The reason I raised that question is he presented recently something, and in one of his presentation, there was a slide of, am I still connected? Can you hear me?
Yeah, we can hear you, Doctor.
Okay, there's one of his presentation that shows the timing, the maximum timing of microembolization in relation to the cardiopulmonary bypass. From the time you start dissecting, from the time you start cannulating and putting the cross clamp, taking the cross clamp off, and as you start rewarming. Do you remember that slide, Ayat?
No, I don't.
Okay, so just ask him to send it to everybody, because I think that's a very interesting work that shows when is the maximum time of microembolization. Another thing for Faisal Al-Ghamdi, you can associate the letter, the first letter of adult, which is A for alpha, and the pediatric, the first letter P for pH. That can help you sometimes memorize at least the status that you use, the strategy that you use. Okay.
That's a good memory tool. Thank you, Doctor.
Okay. All right. I have another phone call on the other side. Please allow me. Thank you very much. Bye-bye.
Okay. So thank you, everyone. We will conclude here. Dr. Abdullah, thank you so much for your attendance and participation. So inshallah, we're going to have the next lecture maybe 5 minutes, 2:45 p.m. Okay, so prepare your slides, please, the presenter. Thank you.
Thank you.
So Dr. Abdullah, you are more than welcome to attend the third session if you are willing to. Dr. Anwar is going to present restrictive versus liberal transfusion, packed RBC transfusion in cardiac surgery. So you are more than welcome if you wanted to.
Oh, thank you. I may have to leave for a portion of it, but I'll try to attend whatever I can.
Sure, thank you.
To another meeting, but thank you so much.
Thank you. Okay, Dr. Anura, you can start.
Yes, السلام عليكم.
السلام ورحمة الله. تفضل.
صوتي واضح؟
Yes.
طيب السلام عليكم جميعا. I am Noura Ibrahim Al-Amri, R1 Cardiac Surgery Resident at the Balkan Cardiac Center. Before starting, I would like to thank and welcome Dr. Hussam for taking out of his time to mentor this session. Dr. Hussam Wali is a cardiac anesthesia consultant at Saud Al-Balkan Cardiac Center. So thank you so much, Dr. Hussam. Today I'm going to present the restrictive versus the liberal red blood cell transfusion for cardiac surgery, a systematic review and meta-analysis of randomized control trial that was published in December 2018 in the Journal of Thrombosis and Thrombolysis. Do we have an issue here with the presentation?
No, I can see it clearly.
Okay, thank you. For the introduction, the cardiac surgery is associated with a high rate of preoperative RBC transfusion occurring in more than 40% of the patients. And although the RBC transfusion is felt to be essential in the life-threatening bleeding in the cardiac surgery, in the most of the cases, the hemoglobin or the transfusion is started when the hemoglobin drops below the comfort zone of the surgeon. And this is largely because of the uncertainty in the safe threshold of the preoperative RBC transfusion in the cardiac surgery, as well as that almost all the evidence are existing from the derived from the non-cardiac surgical studies. So the aim of this review was to evaluate the clinical outcome of RBC transfusion in the restrictive strategies, where the transfusion started at the lower hemoglobin level, versus the liberal strategies where the transfusion started at a higher hemoglobin level for patients undergoing cardiac surgery. So for the methodology and the data resources, there is two authors independently performed a duplicate literature search of PubMed, Embase, Cochrane, and the conference proceeding from the inception to December 2017. And at the right side of the screen, you can see all the keywords that they used in their search. Then the title and the abstract of each study, and if appropriate, the full text screen was performed by same authors, and in case of any discrepancies, it was resolved by a third author. The inclusion criteria, they included any trial that had a restrictive transfusion group versus liberal group. Any trial reported sufficient outcome for the analysis with no restriction was applied on the language, type of surgery, or the type of the outcomes. And finally, the abstract that provided sufficient information also were included. Their primary outcome was the mortality occurring within 1 month of the cardiac surgery. And regarding the secondary outcome, they included the transfusion-related infectious event, the transfusion-related non-infectious event, including stroke, respiratory morbidity, renal morbidity, myocardial infarction, cardiac arrhythmias, gut morbidity, as well as reoperation. And finally, the length of the stay, including both the ICU and hospital stay. For quality assessment, the quality included the studies was assessed independently by two authors based on the study design, blinding, single versus multi-center studies, treatment assignment generation, and the follow-up completion proportion. For the dichotomous data, the pooled risk ratio and the 95% confidence interval were used. And for the continuous data, the weighted mean differences and the 95% confidence interval were used. There is some studies that reported only the median and the interquartile range for the ICU and hospital length of stay. So the estimated mean and standard deviation were calculated for those studies. For between study heterogeneity, the random effect model was used, and the heterogeneity was measured using the I-squared statistics. Sensitivity analysis was conducted for any significant heterogeneity by excluding the trial successively. And for the publication bias, it was assessed by visually inspecting the final plot of the primary outcome, and the J-data score was used to measure the quality of each trial. So regarding the results, there was 9 RCTs were identified that met the pre-specified inclusion criteria. The total number of the patient was 9,000 with almost 4,500 in each group. The study design were different among the clinical trials, including differences in the transfusion threshold between the two groups, as well as differences in the metrics used. Some studies used the hemoglobin level, and the other studies used the hematocrit level. There were no studies that was blinded. There were 3 clinical trials were multi-center studies, and there was 1 abstract publication. The characteristics of the cardiac surgery were different among the studies, including the type of surgery as well as the duration of cardiopulmonary bypass. 3 trials included patient undergoing non-elective procedure. 1 clinical trial included patient with a high CARE score, and another trial included patient with a high ERA score. The randomization of the patients received transfusion was different among the clinical trials, and some trials tracked the intraoperative as well as the ICU and the postoperative transfusion, whereas in other studies, they only tracked the postoperative transfusion and intraoperative transfusion. The total number of transfused patients in the restrictive group was 2,300 out of 4,400, which account for almost 52% of them. However, in the liberal group, a total of 3,300 out of 4,400 received RBC transfusion, which accounts for almost 76%. With at least 6,000 units of RBCs were transfused in the restrictive groups compared to almost 10,000 units in the liberal group. The median number of units transferred per patient ranged between 1 to 4 units. So moving to the primary outcome, there was no significant differences in the mortality between the restrictive group versus the liberal group, as you can see here in the chart. And the visual inspection of the final plot of the mortality to detect any publication bias was reassuring. And for the subgroup analysis for patients who underwent elective or non-elective surgery, they did not show any evidence for significant interaction or heterogeneity among the study level differences. For their secondary outcome, there was no differences between the liberal versus restrictive group in terms of infections, in terms of strokes, in terms of respiratory morbidity, renal morbidity, myocardial infarction, cardiac arrhythmias, gut morbidity, as well as reoperation. However, there was a significant difference in the ICU length of stay among the liberal transfusion in favor to the liberal transfusion group in comparison to the restrictive group. However, even with the significant differences in the ICU length of stay, there was no difference or significant difference between the total hospital stay between the two groups. So in this meta-analysis of 9 RCTs comparing the restrictive and the liberal RBC transfusion for cardiac surgery, the proportion for transfused patient was higher in the liberal group compared to the restrictive group. The restrictive transfusion was not associated with any significant increase in the mortality or morbidity, and there was significantly increased length of stay in the restrictive group. However, the differences in the overall hospital length of stay was not significant. The uncertainty about the safe threshold trigger for the blood transfusion in the cardiac surgery is reflected in a wide range of transfusion rates worldwide. For example, the estimated transfusion rate of allogenic RBCs in the cardiac surgery in the US ranged between 8 to 93%, and in UK it was ranging between 25 to 75%. This uncertainty persists since the patient is undergoing cardiac surgery, received a large fluid load, both from the intravenous fluid administration as well as from the cardiopulmonary bypass circuit, which could artificially depress the hemoglobin level and overestimate the blood loss. In this analysis, they found a longer duration of ICU stay in the restrictive group. This finding could be explained by the consequence of undefined safe trigger for the transfusion coupled with the unblinded nature of the included studies. There is some evidence from RCTs and observational studies in the cardiac surgery have shown conflicting results. In a meta-analysis of 6 RCTs and 39 observational studies of the patient undergoing cardiac surgery, the liberal transfusion was associated with a non-significant lower mortality in the RCT and significantly higher mortality and morbidity in the observational studies. However, the observational studies have substantial heterogeneity and the small study effect. In contrast, the result in this analysis showed no significant differences in mortality between the restrictive and liberal group. Among the 9 RCTs included in this review, different trials enrolled patients with various risk levels. However, in this analysis, they did not observe any effect of the urgency of the cardiac surgery on the mortality. So going forward, based on the current analysis, the given increased risk of transfusion-related infections and non-infectious adverse events, the restrictive RBC transfusion at threshold of hemoglobin less than 7.5 gram per deciliter or hematocrit less than 25% should be highly considered in patients undergoing cardiac surgery. And also, we need further adequately powered trials to establish the long-term effect of such strategy is strongly needed. So if you want to talk about the strength of a study, the first one is the rigorous search of the available literature, as well as they included only the RCTs, which could eliminate the likelihood for confounding biases from the non-randomized studies. If we're going to move to the limitation, actually, we have a little bit of a list. First, we're going to start with the blinding, which was a major concern in the included RCTs, as well as it's not feasible. The blinding is not feasible in the transfusion study, which could have introduced a performance bias in the results. Due to some trial designs and protocol and adherence, there were between the group differences in the hemoglobin concentration and the triggers for the RBC transfusion. And as I mentioned before, there's some studies depended on the hemoglobin concentration and other studies depended on the hematocrit concentration. Only a few clinical trials enrolled high-risk patients and some of them only enrolled emergent or urgent cardiac surgery. Most of the clinical trial lacked the adequate statistical power to detect the mortality, and the composite primary endpoint was used instead. And a different clinical trial used different definition of threshold trigger, and thus introducing substantial heterogeneity in the indication for RBC transfusion. They were not able to examine the effect of the other blood product transfusion, as well as they weren't able to inspect the logistics for RBC transfusion, including the acquiring, storing, and the delivering the RBC product. The lack of the patient-level data also, as they couldn't examine the subgroup of the patient included in these studies. So for the conclusion, the meta-analysis showed that the restrictive strategies for the RBC transfusion in patients undergoing cardiac surgery are similar to the liberal strategies with regards to the mortality and other short-term major outcomes, including stroke, renal morbidity, infections, myocardial infarctions, cardiac arrhythmias, respiratory morbidity, GI morbidity, reoperation, as well as the hospital length of stay. So if you want to go back and assess this study, we're going to start with the first question. Has the main research question been clearly stated? If we're going to go back to the aim, their aim was to evaluate the clinical outcome of RBC transfusion and restrictive strategies versus liberal strategies for patients undergoing cardiac surgery. Again, we have the same issue here. We do not have a cutoff threshold or a cutoff definition, a clear definition for the restrictive and the liberal approaches in these studies. Is it unlikely that the important relevant studies were missed? Going back to the methodology of this review, and by excluding a lot of studies as it weren't meeting or have a different study design and different comparison, we cannot really guarantee 100% that we included all the relevant studies in this review. Were the inclusion and exclusion criteria appropriate? Inclusion criteria, yes, it was a clear and appropriate. However, the exclusion criteria was vague a little bit. Were the included studies valid in terms of research question being asked? Yes, all the trials involved in this review had a clear research question. And was the heterogeneity of the studies identified and adequately explored? Here again, as we previously mentioned in the methodology, we have a lot of discrepancies between the studies involved. Some of them depended on the hemoglobin level, the other studies depending on the hematocrit level, and even the cutoff for between these trials were different. The type of surgery was different between the trials, and even the type of surgeries, the urgency, and the duration of the cardiopulmonary bypass. Were the results adequately presented? Yes, the result was adequately presented. However, were these results provide a clear answer for the research question, or provide us with a clear guideline to change the current practice? I don't believe so. And by this, I reached the end of my presentation. Thank you so much for your attention. And I would be happy to receive any comments or question after clearing the floor to Dr. Hissam for his comments. مشكورا. Dr. Hissam, لو سمحت.
Assalamu alaikum, everybody.
عليكم السلام.
Thank you, Dr. Noura, for going through this meta-analysis. You presented in a very well manner and informative manner. Actually, you hit on a hot, debatable topic for all team members included in the cardiac surgery patient care. But let's ask ourselves one question. Why we are concerned about the blood transfusion? Can anyone answer the question? I think the question is clear on the screen, Dr. Noura discloses. Oxygen delivery, okay? We are concerned about blood transfusion because the main function of the blood is to provide the tissue by the oxygen. What you see in front of you is the equation of oxygen delivery. This equation is very important for the anesthesiologist, for the critical care members, for the cardiac surgeons themselves who are included in the care of cardiac surgical patients. But you are asking yourselves now, why the hell should I care about this equation? Because insufficient oxygen delivery leads to anaerobic metabolism and excessive lactic acid production. This is the hallmark of the circulatory shock. Let's break down this equation and go through the important parts of it. The equation states that oxygen delivery to the tissue equal cardiac output multiplied by 1.39 multiplied by hemoglobin multiplied by saturation plus the oxygen dissolved in the plasma. What you see on the most right of on your right hand, from the most right of the equation, you will find that 0.003 multiplied by the oxygen tension. This is represents the oxygen dissolved in the plasma. And because it is multiplied in a very, very small fraction, 0.003, you can ignore it. So we will concentrate on the proximal part or the left side of the equation. Oxygen delivery equal cardiac output multiplied by 1.39 multiplied by hemoglobin multiplied by saturation. So what is the constant 1.39? In some literature, you will find it 1.34, 1.38. Forget about it. This is the oxygen binding capacity of fully saturated 1 gram of hemoglobin. So each gram of hemoglobin, when it is fully saturated by oxygen, and its oxygenation is 100%, it can carry 1.39 ml of oxygen. Cardiac output, all of us know what is the cardiac output, saturation, the same. So suspect that you have a patient who has saturation 100%, it presents by 1, you can represent it 1, and the cardiac output is fixed. So the main issue of the oxygen delivery is the hemoglobin. Am I right? Noura?
Yes.
Yes.
Yes,
So the
Doctor.
hemoglobin is the major determinant of this, the product of this equation. If you have a patient with a fixed cardiac output, two patients have same cardiac output, 4 liter or 5 liter per minute, and both of them has saturation 100%. So the main determinant of the oxygen saturation is the hemoglobin level. But if you have a patient who has cardiac output high and patient who have a cardiac output low, so not only the hemoglobin will be the determinant of the oxygen delivery. Am I right? If you have a patient with pulmonary problem and his saturation is less than 80 or 70 or 90, the saturation will play a role in this equation. So hemoglobin is very important in the equation. Actually, the oxygen delivery, when the patient is not anemic and he has cardiac output, good cardiac output, and he's a fully saturated, his saturation is 100%, is beyond the lower limit needed for the tissue or critical limit of oxygen tissue. So for healthy young person, you can provide the tissue by more than quadruple times of the oxygen need. So you have a range to decrease in each of these determinants, okay, without affecting oxygen saturation. From here, or from that point, they start to put a level beyond it or below it, this equation will be insufficient to supply the tissue by oxygen. So they say that if you have a patient with a saturation less than 85 or 90, if you have a patient with hemoglobin less than 7.5 or 8, if you have a patient with a very low cardiac output, so the oxygen delivery to the tissue will be decreased. Am I clear till this point?
Yes. Yes, Dr.
Yes.
Hassan.
Okay. Any question about this issue? Any question about the equation or understanding the meaning of the equation?
Yes, it's understood, Doctor.
Understood. Okay. So the restrictive versus regular strategy for blood transfusion, both of them, the end point or the targeted end point of it is to support the tissue with sufficient oxygen delivery. The debate here starts from that some of the cardiac surgeon or cardiac anesthesiologist or critical care doctors, they are misunderstood the main target of the blood transfusion. So if I have a patient with a good cardiac output, and I have a patient who has a good pulmonary function test, and he has 100% oxygen saturation, I can do restrictive blood transfusion. It will not affect the oxygen delivery to the tissue. This is my target. But if I have a patient if I have a patient with CABG and he has not completely revascularized, he has low ejection fraction, his cardiac output is very low, he has some lung problems, ARDS, or has some pulmonary congestion. So in this patient, applying a restrictive blood transfusion strategy may be not adequate for supplying the tissue with the sufficient oxygen. So you can individualize the decision between choosing the restrictive or the liberal strategy for blood transfusion according to the patient clinical condition. At the end, we are a physician, okay? We are not computers, we are a physician. We have a clinical sense, we have to use it. But in general, using restrictive strategy, whenever applicable, is better than using liberal strategy, okay? And this is supported by the meta-analysis discussed by Dr. Noura, that restrictive strategy for blood transfusion is not inferior to the liberal strategy. I think I can, I could explain it in a simple manner. And the floor for you, Noura, and for your colleagues for any question about it.
Dr. Thank you so much, Dr. Hussam.
أيوة أنا سامعك.
Dr. Hassan.
تفضلي أنور.
So from this equation, can we say that cardiac output is equally contributing to the oxygen delivery as the oxygen saturation and the hemoglobin?
Sure, if you ignore the right part of the equation, which is the 0.003 multiplied by the oxygen tension, you can ignore it. So the equation will be cardiac output multiplied by the constant factor 1.39 multiplied by hemoglobin multiplied by saturation. Okay,
so
but remember that all of these are multiplied together. But remember that saturation is presented by, if patient is 100%, it equals 1. So it will be presented in the equation by 1. If it is 95% oxygen saturation, it will be 0.95. So it will not play a major role like the cardiac output or the hemoglobin. Okay, so you can individualize your decision for choosing which strategy to apply for a patient for blood transfusion. You have to put in your mind this equation. This equation, every critical care doctor or every cardiac anesthesiologist is knowing it very well, and he's putting it in his mind while he is managing his patient. If he want to manage his patient on a scientific base or in scientific manner, okay? So if you have a patient with a very low cardiac output, okay, his cardiac output is 2.4 or 2.2 liter per minute. He is suffering so much, and his saturation also not so good, not 100%, say 92, 90, okay? So you cannot also use the restrictive blood transfusion strategy. And I think this is one of the limitations of the meta-analysis or the randomized controlled trials, which is included in this meta-analysis, that not all the patients they have the other constant. The other constant is the cardiac output. So if you have a randomized control trial with all patients have a good range of cardiac output, say from 4.5 liter to 6.5 liter per minute cardiac output, you can here get a proper result of applying restrictive versus liberal strategy. Actually, this is a debatable topic, okay? And I thank Dr. Noura that she has, she was strong enough to go through this issue because even between the cardiac surgeon in the same institutes and between the cardiac anesthesiologist in the same institute, there is a variation. Some are supporting restrictive, the other are supporting liberal. But the main issue is that whether you are supporting this or that, you have to individualize your decision upon the clinical situation of the patient.
Okay, thank you, Doctor.
This is why I agree with Dr. Hussam. So, Dr. Noura, thank you for your presentation. But I agree with this, Dr. Hussam, that we have to individualize patients. So I don't think that we have to go with generalizing the things and reading and applying with the patients. We have to individualize. But what is your opinion, Noura and Dr. Hussam? So do you keep the hemoglobin on a certain number, or it's about the patient? And what is your opinion, your own opinion, your practice? It's, I'm not talking about, for example, guidelines or something. The practice.
It's a good question. Thank you. I want to tell you about my background. I am a cardiac anesthesiologist, mainly pediatric cardiac anesthesiologist. I was working in Magdi Yaqub Foundation in Egypt before I came to Saudi Arabia.
MashaAllah.
So especially in pediatric population, it's very difficult to generalize the restrictive or liberal blood transfusion, because you know very well, as I know from your lecture, that you have a good experience in congenital heart disease. It differs according to the pathology between the pediatric congenital patient. Okay, but I will tell you about the adult. Regarding the adult, my practice is I'm not transfusing blood to the patient if his hemoglobin is more than 7.5. Okay. And the next question you will tell me, your patient hemoglobin is 7.3, will transfuse or not. Okay. I'm doing cardiac anesthesia, TE guided. Okay. And I'm dealing with the fluid management according to the VTI of the patient. Okay. By the TE. So if the patient, I think that he has some congestion or he is hypervolemic, I can use some diuretics to decrease the to increase the hemoglobin up to 7.5 in order to avoid blood transfusion. But if I have a patient who has very low cardiac output, okay, I will not apply for this strategy. Okay, maybe I will shift my threshold for transfusion a little bit up to 8 or 8.5. But in general, I consider myself one of the who are supporting restricted blood transfusion, but I am not أنا مش متحيز قوي الرأي بهذا الموضوع بما يؤثر على سلامة المريض. لا طبعا we have to individualize our decision according to the clinical condition of the patient. For the congenital cardiac surgical patient, for pediatric and neonates, we have other factors affecting our decision in giving the patient blood transfusion or not. Okay, I think this is beyond our topic. We can share this experience later, inshallah.
Thank you, Dr. Hussam. Dr. Noura, do you have any comment, or do you wanna, for example, comment on the article that you have been through? Because what is your opinion? Are you convinced with the things that you have read?
Yeah, Dr. Ayat, thank you so much for this question. Actually, I do not. I am R1 cardiac surgery resident, so I don't have that experience to talk about. But I believe that the restrictive strategy is a preferable for me personally. And for this review, I'm not sure about the, I'm not convinced about it because we lack a lot of the data about the patient, as well as the discrepancy between the definition or between the cutoff between in the studies between that restrictive and liberal. So I'm not convinced really about this study.
Yeah, and let me tell you something. Being R1, it doesn't mean that you don't have to have your own opinion. You should have
No. I
should read more. Yeah,
sure.
Yeah,
No,
exactly.
I'm just telling this. I'm not talking about from an experience.
Yes.
This is just thinking out loud. So
Exactly.
that's yeah.
Thank you, Dr. Anura, and thank you, Dr. Hussam, for the nice discussion. Guys, do you have any comments? Any questions?
Thank you for the panel, Dr. Ayat and Dr. Anwar, and thank you, Dr. Anura.
Thank you so much, Dr. Hussam. I really appreciate it.
Thank you. Any question from the residents? Okay, so we are going to conclude your lecture here, Dr. Nora. And then are we having Dr. Mariam for the next session? Dr. Anwar, you mentioned earlier that we're going to have a session also.
Yes, Ayat, I'm available.
Ahlan, Dr. Mariam, how are you?
I'm good, thank you.
Did you want to
start? Give you guys a break? Do you want to guys want a break, or shall I start right away?
5 minutes from now?
Sure.
Okay, so we're gonna have 5 minutes, guys, and then we're gonna get back for Dr. Mariam Al-Umar lecture.
Ayat?
Yes, Dr. Hagi.
You may want to start by identifying the R7 who are present with us today, so Dr. Mariam can direct her questions or her discussions toward them. Anybody else, of course, can chip in and can contribute, but for us to learn from these sessions, we would like you to observe how the type of questions that people will be facing either in real practice when they are consultant or in the oral exam, for example, when they have a case scenario. So hopefully Dr. Mariam and her team, the scientific team that she's building up, will develop that kind of experience for all the resident and the juniors to learn from. So maybe starting with raising hand, maybe for those R7 so Dr. Mariam can see them and see their names and start directing the questions to them. Regarding the previous session, I'm not too sure if Dr. Hussam is still around, but thank you, Dr. Hussam, for being around. It was intriguing to hear an opinion from a colleague anesthesiologist on the issue. Dr. Anwar raised a nice question, which is how do you compare the power of these things in the formula? And I think you have to look at the real numbers for that, and therefore you'll find the most important one of those is probably, and the one that you can change easily with big changes, is the hemoglobin. And that's why we are usually look at the hemoglobin as an important factor for the oxygen delivery. We can discuss this more in more details if you wish at another session. Thank you, Ayat.
Thank you. Well, yeah, please, R7s, you can just raise your hand because I don't know all the residents, I know some of them. So whoever is there and R7, you can raise your hand. So Dr. Maryam, it will be easier for her actually.
Okay, are we back?
Not everyone, but it's okay, Victoria can start. They will join.
Okay. I still don't see the R7. So if you guys can raise your hand so I can identify you.
If there's none of them, maybe we can move on to R6 if they are interested in this topic.
Okay, R7 or R6?
Interesting, huh? So R5?
Yeah, I'm here, Dr. But I don't know from where I can raise my hand.
I'm here as well.
Can you, let me see, I think you need to go to, yeah, here we go. We have some people raising their hands. Ayat, you can go to the three dots in the lower corner.
I think I'm sharing my screen, Victor.
And then you can show that raise hand and you can use that.
I will try.
Anyway, so you've got Maryam. It's good to see you and hear you again. You got Faisal and you got Amjad and you've got Ayat. I think those are the three candidates for today.
Me also, I'm R5.
Who's that?
I'm Anwar.
Anwar, please, Anwar, please raise your hand so Dr. Maryam can always see you on top of the list.
I don't know from where.
If you go to the three dots in the lower part of the screen and press on it, then you'll have a panel showing where you can raise your hand. Anyway.
On the mobile, if they press, Dr. Farid, on the reactions button, there is a raise hand on the mobile.
Okay. All right.
Okay. So I prepared 5 cases. I was hoping to direct those cases to the R7 so they get the experience of how the oral exam might be. However, we're just gonna pick from those who raised their hand. We can start with Faisal Gandhi.
هلا دكتور.
Okay, Faisal, you are R5 or 6?
R5.
Okay. All right. So we're going to start with the first case now. So just to remind everybody, today's case is about stable coronary artery disease. I actually had a discussion with the R7 and we assigned topics and we'll try every week to discuss a topic. I didn't want to have it randoms because I wanted them to study for it and to be prepared so they can get the most out of it. So today cases is all about stable coronary artery disease. Okay. I know you guys might not be well prepared for it, but we'll go over the case. Okay, Faisal, you can read the case number 1.
Okay, this is a 53-year-old male, heavy smoker, has positive family history of coronary artery disease and hypertension and diabetes mellitus type 2. He has been having atypical chest pain and easy fatigability in the last few months. He was sent for stress test, which was positive. As such, he was sent for cabbage surgery.
Okay. Lisa, do you picture that patient in your mind?
Yes.
Okay. First question. What are the indications for stress test in patient with suspected coronary artery disease?
I would send the patient for a stress test if I'm suspecting that the patient's symptoms are related to ischemia. And usually I would it depends on the probability, the pretest probability of that patient. So if my pretest probability for that patient that these symptoms are not ischemic, I would go with the stress testing. If he comes with symptoms that I suspect that they are ischemic symptoms.
Okay, how would you suspect that patient might be like have coronary artery disease from the history?
First, we are talking about our patient or in general?
In general.
In general, first the patient's characteristics, his age, his family history, his risk factors for coronary artery disease, if he has any risk factors. In addition to that, the patient's symptoms, if he has typical chest pain, especially if they are exertional, these also can guide me toward the ischemic symptoms. If he had any ECG changes that are not conclusive, like ST depressions that are related to atypical symptoms, with the proper history, I might suspect ischemia.
Okay, so what do you mean by typical chest pain?
Typical ischemic chest pain is retrosternal, described as heaviness or compression. Usually it is exertional and relieved by rest. It usually radiates to the.
So if you have the three. Excellent. First off, you have the three characteristics of the chest pain, which is, as you said, retrosternal, aggravated by stress or relieved by rest or nitroglycerin. This is a typical chest pain. If you have this type of patient, regardless of his age, you would refer him for non-invasive stress tests to confirm your diagnosis. Okay. And there is a diagram in the American Heart Association guidelines for stable ischemic heart disease is of how to stratify those patients and when to send those patients for non-stress test. If the patient has atypical chest pain, meaning you don't have the three criteria, but the age is more, for example, male more than 40 or female more than 60, then you might want to send for non-invasive stress. If you have only one criteria of the chest pain or the age is not typical for chest pain, then you may want to follow up the patient or do other investigation. Okay, yes, but I like your answer. Okay, now the next question is, what are the options for a stress test? Are you aware of any options?
Yes, usually we have either clinical, I stratify them this way. We have the physical physical stress test. And usually, and we can diagnose if it's positive or negative. Either it's treadmill, ECG, or echo. or treadmill, yes, or elliptical. We have also a pharmacological stress test, which can be done also by echo or ECG. And we can do imaging, like nuclear imaging, a PET scan with the pharmacologic stress testing, or PET scan to see the myocardial perfusion.
Which one you will choose for your patient?
For this patient, he's
so which one you will choose for your patient?
He's 40-year-old. If he doesn't have any disabilities, and he can tolerate. Sorry, I forgot the age. 53. If he does not have any disability and he can use the treadmill, I will do ECG treadmill stress test. And if he
Excellent. So the first question you will ask whether he's able to exercise versus not able to exercise, right?
Yes.
Excellent. Okay. The last questions are more the indicative positive ECG stress. If you choose to do a treadmill ECG test, what are the indicative for positive?
I don't know really, but I know that
for the sake of the time,
if they have symptoms or any ischemic changes in the ECG, like ST elevations that are in consecutive leads, these are considered positive. But I did not read about it. I'm sorry.
Okay, I can tell you very quickly, but but no problem. So just like in general, you guys would have to understand what are the indicative positive stress tests. So ECG, like treadmill ECG stress test, or echocardiogram, or myocardial perfusion. And there is again a diagram in the guidelines. It indicates all the indicator for positive stress. So for example, for treadmill, if you have any ST elevation, if you have ST depression more than 2 millimeter, if you have any arrhythmia, VT, or ventricular tachycardia, ventricular fibrillation, if the patient, his blood pressure dropped or did not increase more than 120 millimeter mercury, this is an indicator of positive treadmill. Okay, there is others for the echo and for the myocardial perfusion study, but for the sake of the time, I just would advise you guys to read it. Okay.
Okay, doctor.
Faisal, you have the angiogram. If you can just interpret the angiogram.
So this is a coronary angiogram done through most probably the radial artery. Engaging the right coronary artery. I can see what looks like diffuse disease in the proximal segment of the RCA with I will just look at it again. Yeah,
do you want me to repeat it?
No, it is now on repeat. There is like a proximal to mid significant segment after maybe the second acute marginal. I can see from here. Before the second acute marginal, there is a significant lesion there in the proximal part. There is also a retrograde filling of the LAD. I saw in the end, I think, in one of the images, there is maybe what looks like it looks like there is a retrograde of the LAD filling. Yeah, that's it. I see it. And you showed me now, this is the left coronary artery. If you can play it, Doctor. Yes.
Okay. I'm not sure if you can have a control so you can point.
No, I am on the phone, so I think my options are limited. So.
Okay. All right, but I agree with you, and it is really excellent observation of the retrograde filling through the LAD. Not everybody will notice it, but I'll show it to the rest of the people here. But I was very impressed that you picked it up. Let's stop it here. Here. Okay. It will come again. Okay, and what does that indicate?
Most probably there might be a chronic occlusion of the left for the LAD, maybe.
Okay. All right.
This is the left coronary. This is the left coronary system. The circ looks patent for me with no significant lesions, but the LAD here, the left main. Sorry, left main also there is doesn't seem to have any significant lesions, and the LAD there is a proximal significant lesion in this view, but I need to see. This is the spider view, also showing me that the left main and the ostial circ and LAD are patent. But there is also proximal LAD lesion. This one, this is the CTO in the mid LAD. I see it now in this view. And the LAD looks diffused, but I don't see also any significant calcification in his coronary artery from here.
Okay. So can you summarize the angiogram?
This is a patient, 53-year-old, with 2 vessel disease, one mid-LAD lesion, totally occluded, and RCA lesion. He has good targets, good PDA and good distal LAD, visible in the retrograde from the RCA. He's also diabetic. And young, so CABG could be the best option for him.
What do you think about the circumflex and OMs?
I would look at the OM. Yeah, there is, sorry, this I did not notice, but the OM seems like to have a proximal, it's diffusely diseased, and there is a significant lesion in the proximal part. So if I can see it in the surgery, I will bypass it. Sorry, I did not notice the OM the first time I saw it.
Okay.
Yeah, the first
which
OM.
one is the OM? I'm going to show you. And you. Okay, the first one, which is.
Can you stop it, Doctora? Yeah, I will try to find if I can point.
Yeah, I will try to just have. So.
Yeah, the OM is this one coming from this. This is it, yes. This is the OM.
Okay,
yeah.
and this is the first one.
Yeah.
You said if I can see it. What do you mean if I can see it? Do you suspect that you may not be able to find it?
No. First, it comes very high. And also its caliber is like it almost half the caliber of the OM, so it might be small. So
what do you compare it to?
Usually we compare the coronary artery to the size of the catheter, which almost 3 to 4 millimeters.
Yeah, which it's a 6 French, right? Usually they use 6 French, which is?
I think it's maybe 5 millimeter or so.
Okay. All right. So if you compare this diameter to this diameter, what do you think? Is it bypassable or not bypassable?
Now it looks like it's a bypassable vessel. Yes.
It's an excellent target. Not only bypassable. Okay. The size and yeah, the length, it reaches all the way until the lower part of the heart. So you feel that it's supplying a significant area of myocardium. Okay. All right. So they decided to do an FFR to the LAD, to the OM. They were not convinced that it is highly significant. What is FFR?
FFR is functional flow reserve. They measure the flow before the lesion and after the lesion. And then they calculate, and they calculate the ratio. If the ratio is less than 80, it is a significant lesion. If it is more, then it's not a significant lesion.
I agree with the comparison between the pre and post the stenosis, but they don't calculate flow. They calculate
that's
the pressure gradient.
Pressure gradient, okay.
Yeah, before and after the stenosis. But you're missing one condition. They do it under
I remember they used to give adenosine, but I don't remember why.
Yeah, which cause hyperemia, right?
Hyperemia.
Yeah. Yeah, that's true. So they do it under hyperemia with adenosine. Yeah. And your value is excellent. 0.8 is significant. Have you heard about IVUS?
Yes, the intravascular ultrasound.
Okay. And do you know anything about it?
I know that they use it to visualize the vessel diameter, but I really don't know exact. And they will measure. I would assume, I did not read in depth about it. They would measure like a healthier part of the vessel and compare it to this diseased segment that they are not sure about. And if it's less than 50%, they would consider it less than like 70% stenosis or more, they would consider it significant. But that's all my knowledge about it.
IVUS is more objective. IVUS is more objective than the assessment, than the visual assessment of the coronary angiogram, and that's why they're coming and they're relying more on the FFR and the IVUS rather than just the visual assessment of the coronary. It's an objective assessment. So they measure actually the minimum luminal diameter area, the minimum luminal area, not the diameter. And if it's less than 6 in the left main, it's considered to be significant. If it's less than 4 in the other vessel, it's considered to be significant. Millimeter mercury. Okay.
6 in the left main and 4 in the coronary artery.
6 and 4. Yeah.
Okay.
Okay. Millimeter square as a minimum luminal area. Okay.
Clear.
So that's things. Okay. Now, you have the patient, you're in the clinic. How would you counsel the patient for surgery?
I would first explain to him his condition and how many vessels that he has diseased. And I would inform him that according to the guidelines and recent studies, that the best option for patient who's diabetic with 3 coronary arteries that are diseased, cabbage is the best option for him in terms of survival, and he would live longer with less need for re-intervention for any other ischemic symptoms. And cabbage is a more durable option for him since he's relatively young. He's 53-year-old male. That's for him. Then I will inform him about the complication of the surgeries once he agrees to undergo the surgery.
The class of recommendation according to the American Heart Association guidelines for treatment of disease and diabetic patients?
Class 1. It's class 1 indication for cabbage.
Yeah, that's true. Okay.
And I don't know one last thing. I don't know about his echo, whether how much is his ejection fraction, and if he has any concomitant valvular lesion. That would make even the point towards surgery even stronger.
Yeah, that's true. You would order echo for sure. If I tell you you had normal ejection fraction and no any valvular disease, would that change your decision whether to operate or not?
It will not change my decision, but it will make my point stronger for the patient. If he will need any other valvular abnormality or if his ejection fraction is low.
It's normal. No, ejection fraction is normal and all the valves are okay.
Okay.
Okay. Your option for conduit?
My options in this patient, first Lima, and I would use it to bypass the LAD lesion. He's young, so I might think of using do for him total arterial revascularization, but I need to look at the angio again to see if the lesion in the right coronary artery is significant enough to be bypassed by the radial artery. If not, I might use the REMA for the RCA. And the last thing, the lesion in the OM, I don't know if it's significant. I'm not convinced by the coronary angio if it's significant or not. Did the FFR say it's less than 80?
Yes.
So I will try to. I would use rheumatoid AD and vein on both the RCA and the OM.
Okay.
And
And why did you choose? Yeah.
The reason I chose to not to do for him total arterial because I don't want to use bilateral in this diabetic patient who's also a smoker out of fear of the sternal wound infection complication. And the radial, this lesion doesn't seem tight enough to use the radial artery for it. And if I'm not gonna do total arterial, I'm not gonna put two arteries in one vein. I will just put the rheumatoid AD for more survival benefit and two venous grafts over the two.
Okay, so talking about, I wanted to skip this question, but come to this patient is asking about total arterialization. As he read about it, your thoughts. You mentioned this already. You said you don't think the RCA is significant to be used for the radial. What's your indication to use radial artery?
Radial artery is used if I'm gonna use it on the right side. The lesion has to be 95% or the narrowing 95% or higher. And if it's on the left side, more than 90%, because of the risk of occlusion of the radial artery, if I am remembering correctly.
Almost right. So the right it has to be more than 90%. For the left, it has to be more than at least 70% to use the radial artery on the left. Okay, and for the REMA.
The REMA, I really don't remember if it is like the radial artery. It just need to be a significant lesion, more than 70%, but I'm not sure really, because the REMA has the same physiology as the LEMA.
You talked about also like a deep sternal wound infection and bilateral mammary harvest, and you're concerned given the patient is diabetic.
Yeah, this patient, I said I'm not gonna use the REMA for him alone and risk sternal wound infection and not give him total arterial, because I have three targets. I have the OM, and I have the right, and I have the LAD. The OM, I don't think it's more than 90% to use the radial over it. And the right also is not more than 90. So I will be ending up using LEMA and the REMA, one over the LAD and one over the RCA. Now it's more than 90%. The right now is very significant. So I will use the radial over this right. Yeah, I forgot the look. I will use the radial over the right and the REMA over the OM, LEMA over the LAD for him, because he's young.
What is the 10 years patency for radial artery versus grade 7 vein?
70%.
Which one?
The radial artery would be more patent than the saphenous vein.
What's the 10 years patency? The expected 10-year patency for radial artery?
I remember.
Do you recall any trial which compare radial versus grade 7 vein?
No, doctor, I really don't.
Okay, so as a surgeon, we have to know those trials and the patency of each graft in order to justify which one to use in each patient. Okay, so according to the RAPCO trial, the RAPCO trial is compared radial versus REMA versus the grade 7 vein. And the primary endpoint was the long-term patency. It was 10-year patency. Okay. This is a very important trial to look because it will give you the information about the RAPCO. Okay. So that things. Okay, and about bilateral memory, do you remember any, or can you recall any trials can support your argument regarding the deep sternal wound infection with bilateral internal memory?
No.
Do you think it's improved survival, bilateral versus single memory?
One of my weak points is really still the trials. I don't remember all of them, so no, doctor, really I don't. But I know it has a. I know that the
it's really important. Yeah, it's. Yeah, Ayat?
Yeah. Noura. I think, yes, it is bilateral memory. It is associated with improved patency. However, it's also associated with more risk of chest infection. So
what do you
that's
think about survival?
Survival, according to the studies that we reviewed before, if I'm not mistaken, yes, it does improve the survival, the bilateral memory. And we had a guest speaker from UK a couple of months ago. Maybe my colleagues remember. He used to do bilateral memory, and he came here to Takhasusi, and he did like multiple cases, and he was really advocating for bilateral memory. So Ayat, if you remember, maybe you can comment on that.
Yeah, I remember, and he was encouraging doing bilateral memory. However, our consultants in Takhasusi, they are not toward bilateral. They are not toward this. Yeah, and they were commenting about the infection, about it's infection, ischemia, and then I remember the patency. One of them, he was arguing about patency over years, but I don't remember the details about his.
But he was also advocating for patient selection. It wasn't meant for everyone.
Yeah.
He mentioned diabetic patients, elderlies, they are more likely to develop infection. And if we do bilateral memory, then they also would have another risk factor for getting chest infection.
Yes.
Yeah.
But what is the study that supports the survival benefits in bilateral memory?
I'll look for it and I'll send it for you guys.
ART trial. It's the ART trial which compare bilateral memory versus single memory. And actually the primary endpoint for it was all-cause mortality, which basically survival at 10 years. And I'll give you a hint, there shows no significant difference between bilateral memory versus single. And when they look at the sternal wound infection, they found the sternal wound infection was significantly higher in bilateral memory versus single. There's a lot of, debate and argument about the trials. And if you read about it, some of them would say, I would encourage you to read it. We can have it in one of our journal club. It's very important trials and a lot of things to learn from that trial. But in general, there's no survival benefit. Okay. In terms of patency, radial and REMA are more patent at 10 years than vein graft. Okay, so based on this discussion, Faisal, if I can remember, you said REMA to LAD, radial to RCA, and vein to OM.
I have, if I'm gonna use the radial, I will do for the patient total arterial. So I will use the REMA. That's what I think to the OM.
Okay. Okay. So anyway, whatever your decision is, you have to have a justification of why would you want to use this graft. You can argue this patient is diabetic, so you don't want to use bilateral memory to decrease risk of infection. Again, there is no strong evidence. Yes, you will improve the patency, but you may, sacrifice infection.
But I can do it. I can do it skeletonized. That will make it.
That's another thing. That's true. That's one of the things that we can discuss in the journal clubs when we discuss bilateral versus single memory. Okay, so whatever your decision was, you did the surgery, you did CABG time 3, you did Lima to LAD, 7 venous graft to 011, and radial to RCA, and this is your Tamiflu. Tell me if you're happy with your result or if you have any concern.
All are okay, but the PI and the SVG to OM is very high. It's 7, and the flow in the vein, is lower than both radial arteries, and usually it is the opposite. Usually in the beginning, the flow through the vein is better than the arteries. So I am concerned about the SVG.
One by one, Lima
OM.
to LAD. Okay, first of all, Lima to LAD. Are you happy with your result?
Yes. The PI is less than 5.
So what do you want the PI to be?
This is from from the OR. Usually I will try to keep it less than 5, not very high, the PI. But the flow in the artery, if it is, if the flow is more than 10 or higher, especially in the arteries, it will usually improve with time as the artery adapts to the coronary. But for the vein,
that's true. But based on the anatomy and the coronary angiogram, are you concerned? Do you expect that type, of a flow or this flow in the Lima to LAD? Try to remember the angiogram and how the vessel looks.
I remember that the Lima looked okay, and I would not. There should not be any competitive flow because it was chronically occluded, so it should be higher. But since the PI is low, I will not be concerned that much.
What are the other risk factor, factor that may contribute to the flow, other than competitive flow?
I would, if I was worried about the flow, I would fear the competitive flow, my anastomosis, if I have narrowed the native coronaries, like technical issue with my anastomosis.
Sorry, so I'll bring you back to Lima to LAD. Faisal, Lima to LAD with this flow, are you concerned about competitive flow and with those numbers?
In this one, because it's very low, the flow from the LAD, it's 12. The only source that could cause competitive flow is the one coming from the right coronary artery. It could be too much that it is competing with the Lima to LAD, like the radial is giving too much flow, competing with the LAD. But still, with this number, I am not concerned really about the Lima to LAD.
Okay. Have you heard about runoff?
Yeah, poor runoff is when like, let's say if the vessel is diffusely diseased and there is not great good lumen after the anastomosis, it will make the flow less.
So are you expecting this with your vessel? Looking at the LAD that you have bypassed, do you think this is the best result you can achieve, or do you want to revise the graft?
If the distal LAD in the coronary angiogram only showed, and only I was able to see it through the retrograde filling. So, and I cannot judge the lumen diameter by that retrograde filling because it could be underfilled. So intraoperatively, I might pass a probe, like a 1 or 2 millimeter, to check if it has a good patency, good lumen. And if it has a good lumen, I would expect higher number distally.
That's true. Yes.
But I don't know intraoperatively, did it have a good lumen or not?
I'll tell you, if you haven't done endarterectomy on that vessel, you should expect this this flow, okay? Because it has very poor runoff.
But but intraoperatively in this example, the patient had a very diffusely diseased LAD?
Yes, totally included.
Right? No, but I would put my myelema beyond the total occlusion, not over the lesion. Why would I?
So you try to open it. Yeah, not yeah. Yeah, you're gonna open because it's totally occluded. This like from the mid LAD distally, so you'd have to open. Sometimes, if it's very calcified, you have to do a endarterectomy to make sure that you have a good runoff. Okay. We'll move to the vein to OM. What do you? Are you happy with your result or?
No, I am not.
What do you suspect?
Either the lesion is not significant enough and there is a competitive flow, or the OM is diffusely diseased, which I can see that intraoperatively, or my anastomosis was technically not good.
And how to prove?
If it's diffusely diseased, I would have seen it before my anastomosis. If it was really diseased, I would I will say this is the best result I can get. If it is because of competitive flow, I can know that there is no. Really, the only thing I saw in the OR to see if it's significant stenosis or not is passing the probe, distal and proximal. Usually, if there is a significant.
Can you rule out competitive flow?
I am thinking now, how can I rule it out, really? I don't know, really. I don't know how to rule it out. It's just clinical judgment.
Anybody knows? Anybody seen the surgeon?
We can occlude the vessels proximally and see the flow meter.
Exactly. So you're gonna, you occlude it with your back of forceps. You know, the backward, you just turn the forceps and you just occlude it, or you pass a vessel loop and you snare it. Do you know the vessel loop they use an off pump? Have you guys seen off pump surgery?
Yes.
Yes.
If not, you can just like compress the coronary artery proximal to your anastomosis, so you prevent antigrade flow, and you measure the flow in the probe on the graft, and you see if you have if the flow improved, that means it's competitive flow. If it didn't improve, what do you think the problem?
Either it's my anastomosis or poor runoff.
Exactly. Okay, so this is the test which will determine whether you should revise your graft or you should accept it.
Okay.
Okay, and radial to RCA, are you happy with the flow?
Yes.
Excellent. Yeah, I'm happy too. So Faisal, this is the end of the case. I think you did really, really well, given that the fact that you haven't reviewed the guidelines, you haven't reviewed the chapter about stable coronary artery disease.
Thank you.
Any questions about the case?
Mariam, I'd like to comment also on this.
Yes, of course, Farid.
Faisal, you have done very well. I can see why the R7s are not around. Maybe they would have been embarrassed by your scope of knowledge. I doubt very much they are up to bar with this, but maybe because you're in academic center, they stress the fact of all these informations that you have provided. So thank you very much for being there, and thank you very much for picking up the tab. It's very difficult. Actually, it's a typical scenario, but very difficult discussion. And thank you, Mariam, for showing how this kind of interview can be very helpful for all levels. Thank you again. Thank you.
Thank you, Dr.
Okay, any volunteer to take the next case? probably times will not allow us to go through the 5 cases, but we can continue next week as well. But at least let's try to do 2 cases today.
What's the next case topic?
They're all stable.
Okay.
It's all coronary artery disease, so all angiogram and discussion. And, yeah.
Wonderful. Any of the other R5 would like to take a chance, or otherwise we'll try to conclude here and give you a chance to go over it for next week. And again, we will maybe concentrate on the R5. There seems to be the best. Maybe they are the one who should be offered the jobs if they apply early. I definitely will if I was in charge of hiring somebody, I definitely will consider Faisal for that. Not the art. Anyway, so timing wise, we are okay. We can go for another half an hour on one case if you are willing to. If you don't feel that comfortable, R5, then we can delay the discussion for next week if you feel compressed here. Okay. Well, Mariam, looks like you don't have much volunteers at this time. So if you would like to, but this is a very good start, and I really enjoy the discussion. It just shows how much knowledge I'm lacking in my own level. Thank you very much.
Thank you, Dr. Farid, and thank you everybody for attending. Again, I just want to remind you guys, this is just to help you. So it's okay to volunteer. It's okay not to be able to answer the question, but you guys will learn and take notes for the important trials, like for those, like for example, the ART trial, coronary or Ruby for OPAM versus OPAM. You guys initially just have to know what is the trial and what is the conclusion. What did it test? What is the conclusion? For your exam, you would want to know a lot more details about it, but this is a good start. Thank you very much and have a good weekend. See you next week.
شكرا دكتور، يعطيك العافية.